This is the Functional Rehab Podcast with your host, Dr. Ashley Mack.
Let's take another deep dive into headaches. A couple weeks ago, I had the opportunity of interviewing a patient advocate about migraines and how to navigate the system. So we'll take a deeper dive today and talk a little bit more about once you're in the system and working with some of the various professionals who are involved with headaches, and we'll talk about the various different types of headaches. We'll also take a deep dive into cervicogenic headaches, which I find to be particularly interesting because I see that a lot in my practice. And rather than have you listeners hear me talk for 30 to 40 minutes, I thought it'd be a great opportunity to have Dr. Kelokates, physical therapist who actually specializes in these headaches. So Dr. Sam, it's so great to see you, and thank you so much for being on today's episode.
Yeah, hi Ashley. Thanks for having me. I'm glad to be here to talk about headaches with your followers.
Yeah, so let's take a deep dive. And before we take a deep dive and talk a little bit more about that, tell us about yourself and your journey as a physical therapist.
Yeah, so I've been a PT for 9 years now. Came out of school, did a travel contract, came back to Philadelphia, which is where I'm currently at still. I did geriatric care for most of that time for the last 8-9 years. But over the last 3 years, I've really transitioned more into my own practice, focusing on people with headache and migraine disorders.
Very cool. What a journey. I'm so excited to know that you were in the Philly area because that's where I went to grad school. And before we started recording, you said you were actually going to be speaking with the doctors in regards to headaches at Jefferson, which is where I graduated. So I'm very pleased to hear that. So recently I interviewed a patient advocate to actually help navigate the migraine world. So I thought you would actually be really well equipped to talk about some headaches, and especially with the patient population that you work with. So generally, let's talk a little bit more, tell us a little bit more about what headaches are, and then we'll slowly kind of migrate into cervicogenic headaches.
Yeah. So headaches are typically broken down into two types. You have your primary headache disorders and then your secondary headache disorders. Your primary headache disorders, the two most common ones that people are most familiar with, are tension type headache and migraine. And then migraine then is broken down into other subtypes of migraine disorders, like vestibular migraine, for example. And the secondary headache disorders would be ones that are caused from other conditions not related to either another primary cause. So an example of a secondary headache would be cervicogenic headache. It would be also something caused from sleep apnea or cancer. And that's the reason for that headache, is some other diagnosis was causing it. So the relationship to cervicogenic headache is that there's some dysfunction or pain going on in the neck, and that's referring pain up either to the occipital region of the head, so that's the back of the head, the base of the skull, sometimes into the jaw or the temple areas.
So I'm glad I asked this question because I would often categorize tension headaches and cervicogenic headaches together. And so to see that they're two very specific things is good to know. So tell us a little bit more about what those tension type headaches are. Just because throughout my, what we'll say, the training that I've gone through, I've categorized them together. So I'd love to hear the distinction between the two.
Yeah. Well, so there's definitely diagnostic criteria that we're looking for with tension type headache, and that's different from migraine, and that's different from cervicogenic headache. And that's where, when somebody comes into my practice, we kind of sit down and discuss that there's other symptoms involved with these headaches and different causes, and then there's different parameters around them. So, for example, with tension type headache, usually with those that they're having more of a pressure or achiness kind of in the band shaped around the head, the duration of those headaches lasting anywhere from 30 minutes to up to 7 days. So it's kind of actually a broad range. But usually the average is several hours, like 4 to 6. Usually it's bilateral. And then described as dull, pressing, or band-like tightness across the head. That might be accompanied with neck and shoulder pain, but it's not always that. And that's not really part of the diagnostic criteria for it either. Where then we get into cervicogenic headache, and there's a clear pattern that we're looking for with cervicogenic headache to really differentiate that from migraine and from tension type headache. So with cervicogenic headache, we're looking for 3 big things. impaired muscle function. So it's like weakness of the deep cervical flexors and deep cervical extensors. And then possibly like axioscapular, or like muscles that connect to the shoulder blade and to the neck, and just muscle impairments there. And then we're looking for joint dysfunction, and specifically C0, so the base of the occiput, all the way down to C4. And for that, we would do some joint testing and look for abnormal tissue compliance, altered joint motion, and local and or referred pain. So what would happen like during the exam for me is that I'd be doing the joint testing for them, and I'd be asking them, like, let me know if this starts reproducing your neck pain and headache that you get normally. Is it familiar to you? If it's just like, oh, it's painful, but it's not the same pain that I get, then that might not be it. It might be just because I'm on a bony prominence, and that's normally tender for most people anyway. That's not what I'm looking for. I'm looking for an abnormal pain response to that touch or joint play that I'm doing. And then the third thing that we're looking for with cervicogenic headache is restricted neck range of motion. So, general range of motion, looking left, looking right, up and down, but then also doing something called the cervical flexion rotation test, which specifically looks at the upper cervical spine and the rotation you have in those joints.
I really appreciate you sharing that, the diagnostic criteria, because I think especially when folks who are dealing with pain, whether it be headaches, shoulder pain, neck pain, back pain, sciatica, they're just going to search that specific term and then try to find the various different exercises that are helpful. And I had an episode that came out recently talking about it, in a way, like everything kind of works, because if you ever just compare things to nothing, there's going to be some sort of improvement with some sort of treatment effect, right? And so I do appreciate you saying that these are the criteria that help us determine whether it's going to be more of a migraine, a tension headache, cervicogenic headache, because from there, correct me if I'm wrong, it would actually change how you would actually approach treating that patient. Does that sound about right?
Yeah, especially for when it's related to migraine, because migraine itself is a neurological disorder. And that's something where they're always going to have it. And I'm looking to decrease their musculoskeletal impairments related to that. And then also to improve overall health and wellness in ways that fit within a physical therapy scope of practice. So like that might be educating on general exercise and helping prescribe that on a way that improves their overall brain and neural function and health. And then also trying to identify if they do have musculoskeletal impairments that do trigger or reproduce their headache. And then we would address it that way. But the neck pain and migraine is a little bit different, because with migraine, and where that pathophysiology starts, it can refer neck pain. So just because somebody with migraine has neck pain, that doesn't indicate that there is anything wrong with the neck. It can just be referred, kind of like when people have a heart attack and they feel like shoulder or jaw pain. There's nothing really wrong in the arm or the jaw. They're having pain that's being referred. And that's because of convergence at the spinal cord, where you have this pain signal coming from one area, it goes to the spinal cord, and then it gets referred out somewhere else.
Yeah, that makes a ton of sense. And so here you have these diagnostic criteria and what you're looking for. Is this something where you as a physical therapist would be partnering with the physicians who are assessing this to ensure that, obviously we don't have the technology or the scope to actually get those big diagnostic findings like MRIs, CT scans, or like functional MRIs, and seeing how the brain activity works, to determine, like, is it an actual migraine activity or something else?
Yeah, I definitely work with the physicians, at least locally, as much as possible when they do work. So some patients come to me through direct access. So they just call me. I'm probably the first provider they've seen for their headache disorder, usually if they've come to me through direct access. So at that point, I'm going to also then, once they see me and we kind of like figure out what kind of headache they have, whether it's, do I think it's cervicogenic? Do I think it's tension type headache? Do I think it's migraine, or do I think it's something else? Then I'm going to refer to the provider that I think is best for them. Most of the time, I'm still going to refer to a neurologist for any type of headache. But if I really do think it's cervicogenic headache, I might refer to a pain management specialist or orthopedist, depending on like what they kind of focus on. That might be better off addressing like cervical related dysfunctions. With migraine and tension headache, I'm definitely going to go to a neurologist and really try to if I can, get them referred to a headache specialist. So that would be a neurologist that specifically focuses on headache disorders, and they're fellowship trained. And then what we would do together with the physician is that I'm going to coordinate, what other care plan they had, medication, and like at least informing the patient of like medication options so they can talk to the doctor about that as well. Sometimes it's also like, are they decreasing medications? Do we want to try neuromodulation devices like a TENS unit? Or do I think that something's kind of like outside of my ability to help them and they might need further treatments like Botox or biofeedback interventions, which physical therapists can do biofeedback, but I'm not trained in it. I don't know I have any local PTs near me, but I know that there's psychologists in the area that are able to do biofeedback. So if I think they need other services, then I'm going to refer them to them.
Awesome. Being able to have a good, solid team of professionals that you can refer out to definitely helps significantly when it comes to the continuity of care and also coordination of care too, I think. And we are both pretty active on LinkedIn. And I think what's really interesting is that it's a combination of significant collaboration, but also in addition to pretty prominent silos of concentrations where it's like the right hand isn't talking to the left hand. And as a result, things get a little uncoordinated. And that's exactly what we don't want when it comes to trying to manage pain. And so let's talk a little bit more about cervicogenic headaches. You had the opportunity to share a little bit more of like what those clear patterns are. I'm going to ask a very loaded question, but why would people get this? Like, what are some of the risk factors for cervicogenic headaches that people would have, make them more inclined to have that condition?
Yeah. Well, sometimes people just get cervicogenic headache. A lot of people just have idiopathic neck pain, and for them, their neck pain is then generating a headache, and that can just happen for some people. For others, they might have had a head injury or a whiplash injury to where there was an injury to the head and the neck, and that it then caused muscle dysfunction and a joint impairment. And sometimes that stuff can resolve on its own with no active intervention. It's just like, stay physically active, gradually increase your, activity as you feel comfortable. And then like in 6 weeks to 3 months, you'll be back to normal. And for a lot of people, that is what happens. But in other times, they might be a little more guarded, or they never get out of that that subacute phase of healing. So then that's where they might need more intervention to help them get out. Other things that could influence people for getting cervicogenic headache is being in prolonged postures for too long. So it's not really being in bad posture or good posture. It's staying in one posture too long, which can then cause the joints to become stiff. It can cause you to develop muscle spasms or tightness and fatigue that ends up, and as then it doesn't get addressed over many months and years, then you start having this like change in the muscle function, change in the joint function, where you'll see like pain with mobility, reduced range of motion in the neck. And that's where the pain starts to develop over time. So it seems more like insidious of onset, where it just comes in very gradually.
And throughout this entire process, it looks like what you're doing as a physical therapist is collecting not just what we call the subjective information, which is the story that patients and clients present to you. So you're already getting a better idea of what you're working with. But during your physical exam, you're trying to get even more data points to give you a more clear picture on what could be the cause, how can we actually make the changes, which I really appreciate. One of the things that we discussed this before we started recording is the fact that whenever you're experiencing whether it be headaches, shoulder pain, sciatica, low back pain, or anything like that, you go on the internet and you're like, what are the exercises for this type of pain? And oftentimes the challenge is that the pain that we experience could be caused by many things. And I'll use sciatica, for example. Like, it could be that there is a disc herniation or disc derangement. So maybe the people respond really well to, say, back extensions in those press ups. That's why people call it, like, the McKenzie press ups. But there's also folks who are probably dealing more in arthritic stenosis type of like pain, which would respond really well to flexion. So what that means is, like, you Google and you're like, all right, well, the top 10 exercises, probably the first 2 exercises you'll see is both a cobra pose and also a cat-cow, which introduces both spinal flexion and extension. And so it ends up becoming extremely confusing. People are like, I've done this exercise, it doesn't work. And we need, as a community, as a physical therapist community, we need to be in a position where we ask patients, what are they dealing with, but also figuring out what their symptom behavior is like, and then also get the objective data to be able to see, okay, well, what are the causes? What are the things that are most likely going to help? So let's talk about your evaluative process, because I think a lot of people, they may have been disenchanted from their care with the physical therapist when it comes to dealing with headaches. Tell us a little bit more about what your process is like. What can patients expect when it comes to working with a physical therapist for their headache, or what they should be expecting, right? I'll premise with the fact that people say, I never had an experience like yours, actually. And as much as I love hearing that, it kind of disheartens me a little bit, because it's something that I just believe that every other PT should be going through. It's like, collect information, figure out the objective, then treat, versus, oh, you have pain, here are these 13 exercises, right? So, sorry, I'm going to stop talking, but tell us a little bit more about what your process is like, what patients should be expecting when they go get this.
So when I go through my evaluation process, it even starts at the first phone call, just the initial consult, realizing like what their problems are, to see if they're even appropriate for me, or they need to see a physician beforehand. Because it's sometimes like, just in the screen, I'm like, no, you sound like you need medical intervention more than you need physical therapy intervention first, and we'll go down that road. Especially like I've caught a couple times people with what's called a CFS leak, cerebral spinal fluid leaks, just on the initial phone call, and refer them to a specific clinic for those types of headaches, which would be called low pressure headaches. And you can kind of screen some of that just in the phone calls. But then when somebody comes in, I've kind of already gone through like the basics of like the general problem they're having, and have an idea of what headache I'm probably dealing with just based on the initial call. But then we really get down into like the weeds of their specific presentation. So I'll talk about, do they have a headache history with family members? So that can be really telling, especially if for the condition they have, if there's a genetic component. And then from there, we talk about the headache characteristics they have. So I'm looking at the quality of the headache, the intensity of the headache, and the location of the headache. And for many of the people that I'm seeing, especially if they have migraine, they're also presenting with a secondary headache. So either cervicogenic or tension type headache. And I'll also clarify those as well and differentiate those. So then I can better explain to the patient later on, like when we go through the education of what I found during the exam, what the different headaches are, what's causing them, and how they influence each other. After I talk about the headache actual characteristics, then I go down into like accompanying symptoms. Now, I would expect somebody with cervicogenic headache to say no to a lot of those questions, but somebody with migraine would be saying more. So I'd be asking about nausea and vomiting, sensitivity to light, sound, and smells. Do they experience any aura? So most people are commonly are aware of visual aura. So that's where they might see like shimmers or sparkles in the eyes, or have like a kaleidoscope kind of like vision during attacks. But there's other types of auras as well that people are like less so familiar with. That might have to do with like hemiparesis of the face and the upper arm, or dizziness and vertigo, which would be common for those with vestibular migraine. Might ask people about aphasia as well. And then some of these other accompanying symptoms might indicate that, like, oh, there's something else going on. It's not just migraine, it's a migraine-like presentation, and they might need a referral to a neurologist to deal with those conditions as well. And then after I talk and ask about accompanying symptoms and getting their history for that, I'll talk about like their perceived triggers or things that make them feel a lot worse. So that would be talking about sleep, whether it's sleep position or the total like sleep quantity and sleep hygiene. This also gives me a lot of ideas about what their lifestyle review is. So like, what are their sleep habits? How do they do stress management? Are they physically active? Do certain physical activities make them better or worse? And that gives me a lot of information on how I might tailor a plan of care later on. And do I need to address certain things earlier? Like if I see that somebody has poor sleep habits, well, I'm going to start addressing that day one before I even start doing some manual therapy, because that's going to have a bigger impact on pain in the long term than my short-term interventions. And then after perceived triggers or exacerbating factors, I try to see if they have anything that helps them, any attenuating factors. Are there medications that work? Is it rest? Do they have any like at-home devices that they might like? Do they have like a neck traction device? Do they have a TENS unit? Do these medications work, but then give them other symptoms that make them feel worse or give them brain fog or anxiety because of the side effects of those medications? And then after that, and I go through like my whole like subjective part, which gives me a lot of information and really helps me pare down my physical exam. Because like the physical exam I have as far as the template is really long and in depth. But if they don't have certain symptoms, then I know I can cut certain things out. Like if they don't report any dizziness or vertigo symptoms, well, I know I can probably not do the vestibular exam, or at least I don't need to do it today in this first initial evaluation. But in the physical exam, I'm going to start one assessing posture. It's not always that like, oh, they have forward head posture, so they got to fix that. Or they have this like, rounded dowager's hump at the top, and we got to fix that. It's not always about fixing stuff. It's just making notes of where they might have different stresses across different joints or muscles so that I can take into account their posture for different work-related positions or how they might want to sleep and reposition the bodies there so they're in more comfortable positions. And then from there, one of the big questions I ask is looking for signs of craniocervical instability, which seems to be pretty common for migraine and cervicogenic headache, less so common with tension headache. But that would be like the common classical signs for craniocervical instability would be like wanting to crack your own neck a lot, like self-manipulate, feeling like your head is too heavy to hold up, especially at the end of the day. Or you might even find that that person is like holding their head in their hand, or like the way they position themselves on the sofa or in their car, that the cushion is cradling their head to be more supportive. That would be an indicator that there's a muscular weakness there, or some type of neuromotor control dysfunction, that they can't really control the head on the neck. Right. And then that would guide me a little bit more on really assessing and testing for muscle dysfunction. So with that, I'd be doing like the deep cervical flexor endurance test, really seeing, can they do a chin tuck, and then can they maintain that in lower cervical flexion as well? A standard measure for that would be like a 30-second hold, but most people are failing that within 4 to 10 seconds. And what I'm looking for is, are they losing that chin tuck, and are they compensating with like the sternocleidomastoid or other neck muscles to lift the head and the neck and not able to maintain that chin tuck position? And then after we kind of do that, I go through kind of the joint assessment and see what kind of their joint play is. Does that reproduce or resolve symptoms for them, or does it not influence at all? And then from there, I might get into like special tests, and this would be like a specific test to reproduce and resolve the headache, adding manual pressure to certain points on the neck, whether it's a muscle or joint line. I might look at range of motion with something called the cervical flexion rotation test, which biases the upper cervical spine in rotation. If I feel like they do have a motor control issue, I would do something called the cervical joint position error test, which I'm looking for the proprioceptive control of their neck and seeing how well they can control their head. For most people that I see, if they, back to like the craniocervical instability signs, if they talked about a lot of positive check marks for those questions, I'm probably going to do that test, and I'll probably see a positive result, which means that like they're going to fail the test. So, but with a lot of those tests, it's going to help me really guide my plan of care as far as what exercise I want to do, what manual therapy I do, or what manual therapy I don't want to do.
Yeah. So it seems like you have a pretty comprehensive approach to actually even just getting enough information to determine what your treatments are going to be. And I think for the listeners, and probably for a lot of other physical therapists as well, we're like, wow, that's a lot of information that you get. And I know that for myself, whenever I'm doing pain management, again, for shoulder pain, back pain, sciatica, stuff like that, I need to get enough information for me to be able to make a specific decision. Medicine, especially in pain management, is in a way kind of like a process of elimination. We say, okay, you have a headache. All right, well, what are the types of headaches that are out there? And it's like, we have these, primary and secondary, but each one has a subset. All right, well, let's get a little bit more information. From there, we start eliminating, all right, well, it's most likely not a migraine, most likely not going to be a tension headache. All right, we're thinking that it's going to be a cervicogenic headache. Let's get some of these more tests to continue to confirm. And what's interesting throughout all that is as we're getting these data points, it either confirms or refutes our specific hypothesis, right? Mm-hmm. And I think what's interesting is the fact that a lot of people expect that when they go to a physical therapist or to a doctor, that they're going to go in, they're going to have a definitive diagnosis. As in, they go in, they're like, I have cervicogenic headache. So moving forward, I am not going to look at anything else aside from that, because this one clinician who maybe gave a 10-minute assessment said that I have cervicogenic headache, which means that even if someone says you might have something different, it kind of closes it off. So my recommendation for you listeners out there is, as you're going through this process, in a way, kind of time what your interaction is with your provider, and then also see, are they asking a lot of these similar questions or looking for these similar things, just so they can get a better understanding. I think the medical community, like, everyone in it is brilliant, but the unfortunate reality is the fact that you can't get all the information like what Dr. Sam was getting within a 5-minute evaluation. Like, that's just impossible. We can get to conclusions relatively quickly, but we need to have an opportunity to get the information that we need in order to actually determine what's going to be the best for you. And we might have a good idea on session number 1, but that might completely change on the 2nd, 3rd, 4th, or maybe even the 6th, 7th, and 8th visit, right? Every opportunity, and this is how I was brought up, and Dr. Sen, you can let me know if you agree, is that not only are we focusing on providing treatment, but every time a patient responds to whatever we're giving to them or providing for them is going to give us a better idea of what the next steps are. Do we need to progress? Do we need to regress? Do we need to change our direction because we're actually looking at the wrong thing? Would you concur with that?
I do. Yeah. And it's one conversation I have with my clients, especially during the evaluation, is that they need to be an active participant in their care and really give me a lot of feedback on what the treatments are doing to them. So, and we need to have this like open line of communication. So I know that some things that I do will reproduce or cause a headache, or in some cases with migraine might cause a migraine attack. That doesn't mean that the treatment was bad, but we have to at least reassess it and evaluate, okay, is this something I still want to do? Was that an expected response for the treatment with where we're at? So like the first time doing a new exercise or manual therapy technique, yes, we might stimulate a headache, and that's okay. I'm looking for, is this repeatedly happening? Is it getting better? Is the headache getting less intense? Is the neck pain improving? What are the other parameters going on? So we can really assess, is this making you better or is this making you worse? And that open line of communication is really helpful to me as a provider to make sure that I've tailored that program specifically for that person, so they really feel like they're getting helped, and they're not just like being thrown into like some generic program that it helps a lot of people, but it's not specific to them, so they're not going to maximize their improvement.
Yeah. So, we gather this information, trying to identify patterns, and things will change. But as Dr. Sam said, tell your provider everything. The challenge with pain is that it's an experience. And so the best way that we can measure it is through your subjective rating, whether it be through the objective test that we give you in regards to like, tell us the level of your function. But also you can be a high functioning person with a lot of pain and still we can't see that. And so if you can provide us more of a clue of what you're going through, it allows us to do our jobs better. It's a lot different than compared to trying to treat something like high blood pressure or diabetes, where we actually have like a true actual number and we can see that. It's really based on, how does this make you feel? And it might be challenging to describe what you're feeling, just because, I know out here in the US, like, it's not very often that we have the opportunity to share like how we're truly feeling, right? And so consider when you're working with a physical therapist and even someone like Dr. Sam, that we're providing you a safe space to tell us, is it working or is it not? And it's not going to offend us if it's not working. It actually will make our lives a lot easier if you tell us that something isn't working, so we can move on to the next step. We're here for you. So that's the key. Dr. Sam, this has all been really helpful. And one of the reasons why I was interested in, another reason why I was interested in speaking with you is that you actually work with clients online through a couple different means. So tell us a little bit more about how you can help clients dealing with headaches.
Yeah. So I treat locally in Philadelphia. So I'm licensed in the state of Pennsylvania to provide physical therapy services. I can do that in person. I do house calls within the city as well. And then I can do telehealth within Pennsylvania. For patients outside of outside of that area where I'm licensed to treat, I do have like wellness plans that I work with patients on, and I do have like other providers around the country that actually refer to me to help with patients, getting back into being more physically active. A couple cases, or I guess examples, would be like their headache disorder is much more controlled now with medication management or Botox or like neuromodulation device like Cephally, but they're having a problem getting back to like CrossFit or biking or playing with their kids where, they're carrying around their child and it's starting to stimulate a headache again. Okay, how can we make a long-term exercise plan to where you're not being triggered anymore? You can gradually get back into it, because sometimes people just want to get back into what they were gradually doing, and they need a more like stepwise progressive process. So we can sit down and really talk about, okay, how do you want to, what lifestyle do you want to be live as far as physical activity goes? And then really plan out what they want, and then give them specific things that they can start working on, and then parameters to stay within so they don't frequently trigger their own headache attacks with just general exercise.
Beautiful. So for the listeners who want to get in touch with you and hear more, right? What's the best way to get in touch with you?
The best way to get in touch with me would be either going to my practice website, which would be kelosphysicaltherapy.com. I'm also active on Instagram, like sharing posts, usually at least weekly. Sometimes I miss. I get a little busy with stuff because I'm a solo practitioner, so I get a little caught up treating some days and don't have time to post. But I'm usually pretty active on there and responsive to messages, and they can always just call the practice if they want to learn more.
Beautiful. I'm going to go ahead and put that contact information into the show notes. So if you didn't get a chance to write that down, it'll be found there. Dr. Sam, it was great seeing you, and I really appreciate you taking a deep dive into headaches and into the headache world, because it's certainly a very big world. And I think that what we were able to accomplish today was make that a little bit more clear for the folks. So thank you.
Yeah, thank you for having me. I was glad to talk about it and help people learn a little bit more about what a physical therapist can do to help them with headache, because really there's just not a lot of physical therapists that specifically specialize in these disorders in the United States. So it can be really hard to find somebody that's helpful and know what to look for and feel like, oh, I'm getting the care I really deserve.
And you, listeners, deserve the best care. So thank you.
No patient-therapist relationship is formed by listening to this podcast. We are not providing medical advice, and all information should be confirmed by a medical provider.